A pleasure to be here, and I would really thank everybody to invite me. It's something that I really enjoy in terms of my work, in terms of really planning what we do. And this is something that I do see quite often. A lot of patients now are extremely well read, and this is a patient website called KC Global, and I would encourage doctors who are treating keratoconus to see this website, because a lot of them actually have good amount of information, and it's actually true, all of us versus keratoconus. Now, the concept of keratoconus management is actually quite straightforward. The picture on your left and your right require similar managements. You need to stop the progression, stabilize the bulge, you need to improve the contour through intervention, and you need to have measurable results. Just for the record, that is not me. So interventions for keratoconus can have basically broad interventions, which is in front of the cornea, on the cornea, in the cornea, and then beyond the cornea. And I'll just touch upon some important points as we go along. The combination, of course, is with respect to cross-linking include Intacs, ICL, and PRK. I'll touch upon these three areas where I've had a good amount of experience as well, and I look forward to other people's inputs. And the common questions are broadly single sitting versus sequential. Basically, cross-linking alone can be used as a pre-treatment. You can combine it with topo-guided PRK, basically depending on your preference. Now, when you look at keratoconus, you have multiple options of PRK, CXL, ICL, and there are, of course, different things. You need to understand that the biomechanical cellular process is unpredictable. There are different ablation rates. Post CXL and ectatic corneas are different from a standard cornea. And when you are planning for an ICL, you need to have stable refractive correction. And these are important principles beyond which you really need to plan. And this is an approach that I use fairly commonly in early and advanced keratoconus. And this is mostly based on imaging. And I'll go over this because it's slightly busy. In early and moderate stage of keratoconus, which is progressive with regular astigmatism, usually good vision is there with contact lenses. You can do a CXL followed by a contact lens or even a toric ICL. You can do intracorneal rings, whichever you prefer, even the canes. And if you have irregular astigmatism, you can do asymmetric rings followed by the use of collagen cross-linking and followed up with an ICL. That also is quite acceptable. Now, these are kinds of cones that usually will work. The picture on your left is a fairly regular astigmatism, predominantly central, so you need a combination of what I mentioned. In irregular astigmatism, where the cone is not within the first central 3 to 5 centimeters, you need to do 3 to 5 millimeter rings. You need to look at asymmetric rings. Now, you can, of course, get fairly advanced cones as well. If you have central scarring, you need to do a DALK followed by an ICL. And if you have a fairly advanced cone with no central scarring, you can do a combination of collagen cross-linking. You can do a steep ring, intracorneal ring. You can do a CXL and still actually give them good visual results with an intracorneal ring segment. This is one patient who is now a student of mine, following up for almost 8 years now, and you can make out a slightly eccentric cone. And for this patient, we did an asymmetric ring, a single ring in the inferior part, which really pushed up the cone. And over a period of time, you can find that the cone actually responds to the ring very well. With a contact lens, she sees 6.6 and uncorrected 6.12, 6.9 with glasses, equally very, very good. Surprisingly, you need to also check the mother, and this is the mother who came with cataract, and we found that she has an irregular cornea and almost like a PMD. So it's probably a spectrum, and it's important that you look at the mother or parents of these keratoconus patients. Both eyes, we actually did a surgery. Now, our results based on that nomogram is actually very good, almost about a 4 diopter spherical equivalent reduction pre and post treatment. Improvement in uncorrected and best corrected vision. So this is important when you're treating these patients. Just also to mention that you can do it fairly young. This is the pediatric Intacs. This is important because you need to look at the depth of the placement of Indra ring, and a post-op OCT definitely helps to make sure that you are at the correct depth. I usually prefer about 80% depth, and this imaging of an OCT actually helps. There has been newer developments of using corneal wavefront. Remember that Over the cone, the cornea is thinner. You have slightly thinner epithelium as well. So the present nomograms present across most machines now allow you to actually have a differential ablation. And I feel that really works well. I have experience both on the wave light and the Schwinn platform, and a trans PTK with an extra ablation, and the cone can actually be minimized. It works quite well. You can play around with this screen where you can adjust the amount of ablation that is required. And this is basically the cone that you get. This is the cone, this is the area of the ablation, and you can make out that over the ablation, over the cone, the ablation tends to be slightly less. You can actually customize it to the amount of wavefront that you use. You can get counts results like this. This is pre and this is post, fairly regular, corrected with a glass. Our 1 year results show, usually for early cones, quite good. About, you start with about 2 diopters. They are slightly myopic or slightly hyperopic, and since they are young patients, they can accommodate actually quite well. This is a post-DAL patient, post-keratoplasty. Even in this patient, what we found was, if you do topography guided, this was on the wavelight, you do multiple serial images, you do the planning in terms of the spherical astigmatic correction that you want to do. This is the treating image, where basically there is a variation in the amount of ablation across the whole cone and fairly regular results. And these patients do see not a very significant improvement, not only in the glare and the halos, they do get good uncorrected vision as well. This is pre-post images. Eye trace I do use quite often. This is a patient post intacs. Remember that we've done bilateral intacs, so intacs, and we find he's not really very happy with the vision. So how do you actually improve this? We did a topo guided treatment after the intacs, and you can see that there is a simulated improvement. Patient does see an improvement both in the uncorrected and the best corrected, and he's now following up his medicine in the UK. Toric lenses, also an important part. Remember, you can use phakic lenses or toric IOLs. Results have been there in both. I prefer the ICL, but now a slightly more conservative, because now we have fairly long-term follow-up on these patients. A lot of them actually end up with a bit of hyperopia. So you have to be definitely maybe a -1 post-surgery. We were expecting emetropia, but a lot of them end up with hyperopia. So my take-home message for this should be to try and really aim for myopia post-ICL. In conclusion, you have a combination of collagen cross-linking, intracorneal rings, toric ICL, PRK, CXL. They are good, successful surgical alternatives. Planning for surgical options is based on preoperative imaging. This basically helps in optimizing our results post-operatively, and this is extremely important because these are young, very young patients. And based on our nomogram, we found results in terms of predictability to be very good across toric ICLs, PRK, and intracorneal rings. Thank you so much. And